still do 1 day a week. One day a week clinically. I think it sort of helps me know what the challenges are in real life, what we're dealing with, but the majority of my time is working with the shaping of services.
Thank you. Hi everybody, thank you for coming. My name's Jill Bijou. I'm the Chief Executive of Croydon GP Collaborative. We're the federation that represents all practices in Croydon, so we run some services, but we're here really to represent the patients, our members, and really to advocate and support practices and the patients.
Evening everyone, can you hear me? Yeah, it's working. I'm Bianca Bowler, I'm Director of Commissioning, Policy and Improvement for Social Care and Health at Croydon Council. It's lovely to see you all here this evening. Annette was due to be here, our Director, unfortunately she's not very well, so I am standing in for her, but hopefully I'll be able to answer any questions you have. Welcome to see you.
Hi everyone, I'm Sarah Burns. I'm Chief Executive of Croydon Voluntary Action and Freedom Children's Trust, and we're looking to merge those two organisations, both of which are the infrastructure groups for the borough. Freedom has a very young people focus, CBA is a full community, the whole voluntary sector, so we look to network and partnership and collaborate across with all partners. That's how we're looking. Thanks, Freedom.
Sorry, I've got a bit of a croaky voice. Can I say it's not so medical? No, I can't. Okay. So, my name is Eula May, and I'm the strategic lead for the Start for Life programme, which is part of Family Hubs, and I lead the Start for Life programme in the borough. So, my work centres around families from pre-birth to childhood. In this borough, which, as has been said, is a very large and diverse borough, we do not have a tongue-tie clinic. So families where there is a child with a tongue-tie are sent out of the borough. Are there any plans to bring a tongue-tie clinic into the borough? We know that sometimes when the families are sent out, it's quite a long wait, and as much as we know that a tongue-tie is not life-threatening, it can impede feeding, and it can be very anxious for parents.
That's all right. I suspect a question for me, which is fine actually. You bring the topic close to my heart. All 3 of my children had a tongue tie, and in fact one had what's called a posterior tongue tie. It's slightly harder to diagnose, but had feeding problems and all sorts. So you're right, we don't have one in the borough. I don't know if there are immediate plans on this. I know that they do have the service in Kings in South East London, and you'll be aware of that. So I think our patients who need it, we can refer to that area. The question around if there are any plans, I would need to have that conversation with our ICB to know what that is. I probably should, but I don't know the number of patients we get, or patients is strong. The children we have that need the procedure, A, the diagnosis, and then B, a treatment, which is actually really quite simple.
In the last 6 months, it was 64.
Really? So when I had my children's dealt with it, was at the Kingsborough, and it was done in a little surgery somewhere, very quick and easy. Let me take that question to our ICB colleagues. But the theme here, if I have to bring it back, but Gordon, you can expect a long email soon. I will look at that because you don't need to sell me on the cause. It's traumatic, primarily for mums and babies and the breastfeeding and all the rest, but then it goes on to speech and the rest, so I'm very sorry.
Thank you.
I do have a question. My name is Chifunda Stubbs, and I work as a practice development manager for sickle cell. Yeah. So basically, what it is that one of the things that's been missing in Croydon for a little while is apheresis services for the sickle cell patients.
Which service?
Apheresis. Yeah. So for exchanges. Yeah. And I just wanted to know what the plan is for Croydon, basically, because that's one area that we're letting our patients down. Thank you.
That's all right. Hi, thank you for that, and good to hear the work with sickle cell. It is a big priority for us at the Trust. We've been doing a lot of work in the sickle cell area, primarily due to our population and it being a higher issue for us, I think, than most boroughs in the region. We had it down as one of our Trust quality priorities over the last year, not just with the exchange service, but with time to painkillers and sort of dedicated patient service is indeed coming. We've had some funding through Central, through a bid from our haematologists. We've worked up a business case to do that, and we are hoping to be able to lap that over the next few months. It won't have escaped you, there's national financial challenge, so that plays into it, but it remains a big priority for us at the Trust, and we're quite committed to doing this piece. I can't give you an exact timeline right now. I'd like to be able to, but my haematologists are regularly knocking on my door. We've got the case together and we are working towards that. I think it's a big ticket item for us. Does that answer your question? I hope to have a more productive answer then. But yes, absolutely.
Following on from that really excellent question, I know there's gene therapy and there's potential cure for sickle cell. I know the cost is very high, but it is a possible cure, and I have seen reports lately that someone has actually been on the trial and it's made a huge difference to their lives. Subject to the cost, we are the largest borough population in all the London boroughs. We are very diverse. We have a lot of sickle cell sufferers. Is there any way we could make a bid? I don't know how it works in that respect, but that gene therapy, I know it's got risks and it can't be for everybody, but is there any way that that can be available to some of our sufferers here? It actually saves and changes lives.
So thank you for that question. I have to be honest, I'm not a haematologist by trade. I treat sickle cell patients at the front door, but what you're talking about sounds like evolving research and still in the trial phase. It's not something I've come across. I don't think it's certainly evidence-based standard treatment now, but I think your question is there any way we can be involved? We have a very active research and development department at the Trust that works within the Croydon Health Services and out in the community. So then with our haematologist, I will certainly ask the question, and I think probably is my easiest point of contact. I'll come back through Gordon to give you that answer, if that's all right. But a lovely question, I will take it to my team. It's just not something I know enough about, and I don't want to make it up. But very good question, and I'd be keen for us to get involved in some community-based research. We're doing a lot already in different spheres. I don't need to make the case here for why sickle cells are important for us.
I'd just like to ask, my name is Paulette Lewis, and I'm here as a chair for the Croydon Lily Forum today. I do know many of you. Now, the demographic of Croydon is such that one of the issues that I hear through that forum is around language. We're talking about speaking up, and we're talking about information for our clients in Croydon. We have over 51% of the demographic is from Black minority ethnic group. So one of the questions I'd like to ask, I was asked to ask is that, so where is the information? How many languages have we got all of this information in the wards? How do we, when we look at the strategy here, we talk very much about embedding residents' voice. What I'm hearing is that many of the leaflets and information we have is not written in the language of the majority of those people. So how then do we engage them in discussions that we want them to engage? If you look at here tonight, I can't see a good representation of what the Croydon reflects. So is there something about information, how those are given out, how we invite people to meet, and should we be asking them to meet us? Or should we be finding out where they are and then go and engage with them? One of the things we need to do is turn it on its head, because people are not reading some of the things we have. Technology, I know it's, we're improving on technology, but not everybody can afford to have the technology and things and emails. So I would just like to raise that issue, because it's about information is power. And I think some of the people from that group feel that they're not getting information in language that they would probably understand or better engage with the community through health and social care. I know it's difficult, and I know we have to have some cash and things, but I think there are groups around that speaks different many languages, and how do we engage? We sometimes work in silos. I think looking at your strategy, there's something about collaboration. We have so many different groups in Croydon
still working in silos and we're not collaborating as much as we can. So my question and my guess today is that can we go back and look at through the ICT or whatever, how are we managing? There's over 100 languages spoken here in Croydon, but if you do a survey now, I don't think you'd have even 5% of the languages in some areas. Some people cannot, and they depend on people to translate for them, and they're finding it quite difficult. Thank you.
It's very much a challenge for us in the emergency department and in all services, but it's probably most reflected in the ED when people come in not anticipating that morning they're going to end up in hospital. We have a number of avenues that we take in the trust. As you say, 70% of our staff are from local Croydon, more than 50% of BME. That gives us a great resource in terms of translation, but with 100 languages, not always. We do have technological approaches.
How many interpreters do you have in hospital?
So we also have an interpreter service that we subscribe to for language line, which I was getting to. So if we don't have someone from staff in the department, we use language line, which is, to be honest, it's a bit tricky because you're using a telephone, but when you need information, it's all you've got, and we sort of make do with what we have. So, or that we do use quite commonly, and that's very, very helpful. So there are a number of avenues we take. I think just more broadly, to Paulette's point here about reaching into the community, I think we will agree, I think we're the same across the panel, to a degree we're here today, but this gets trickier with the groups that you're talking about. We're really talking about the hard to reach groups, those people that aren't coming out and representing themselves. So we've done a couple of examples through the trust, much more to do in this space, but there was a man in a van, which was a drive to go out and test prostate-specific antigen. I won't talk you through the sort of old-fashioned way of checking for it, but men of an age will know what happened when you went to the doctor. Now, we've gone out and we did a blood test, and that's helped us pick up, particularly in the black community, a good number of early prostate cancers. The earlier you pick them up, the better. Organ donation, a very sensitive subject. And actually, we've had real trouble with reaching certain parts of our demography. We've ended up going to temples, to mosques, and to different institutions. So all I can say is you're absolutely right. We need to reach out into those communities, and that means taking the time, making the effort, and working out what the big ticket items are to do the most for the most.
To all sectors of the community, but that's not what this session is about. So I wonder if perhaps we start at that end of the table. We should have a bit of a break. I would ask each person if they could talk a little bit about what they do in their organisation to make sure that they're getting through the information in a way that people can receive it and understand it.
Thank you. Great question, and really welcome it. What we're trying to do with all the collaboration through the local community partnerships, through community hubs, through bringing voluntary sector groups into the space to be able to use the communications that they know work well with the communities that they're serving. So recently I went to the Refugee Day Centre. Huge amounts of language is spoken there, and the communication is beautifully tailored in a way to the different communities because the language is, the people there are tailoring the communications specifically. And they're very cautious about actually allowing the kind of the publications that come from on high down because they just don't make sense to people. They're overcomplicated, they're medicalised, they're not the kind of questions that people, understand and want to, inform. The other way that I think is really important that we do, not only in those kind of like bringing people into our local community partnerships, into community spaces to be able to access that voluntary sector work. The other thing is through local people reaching out and having conversations in seldom heard communities. So we would call this asset-based community development or use the role of community builder, but it's about going into places that are seldom heard, communities that are seldom heard, or estates or streets that get overlooked, or particular communities, to help with bridging that gap, and ideally with somebody who's from that community to be able to essentially translate, put in peer terms so that we all know what we're talking about. And in that way, that word of mouth is so much stronger than something that has been beautifully co-designed through lots of institutions. So that's what we're trying to do, and it's a real invitation to get involved, because we want to all have that kind of joint collaboration to own it, because as you say, it's a huge communication piece to do, so we all need to play a part.
Thanks, Sarah. So a couple of things from me, I guess, from adult social care. How we provide information, advice and guidance is a real challenge for us, actually. And under the Care Act, we actually have statutory responsibilities about the provision of that information. So we've just undertaken quite a big review of how we're providing that information from an adult social care perspective, but it also goes across the whole council. And there's a work stream at the moment that's underway at corporate level in the council, again, reviewing how we're providing that. We can do much better. I don't know if anyone's tried to find something on the Croydon Council website recently, but it can be a bit of a challenge. And we know that, and we're actively working on it, because it is really, really difficult. But there's something for me also about us not prescribing how that is provided, because how I might respond to something is not necessarily how someone needs us to respond to, if that makes sense. So how I might think a leaflet needs to be written isn't how someone who needs that information might be able to take it in and understand it. So we're looking at setting up a resident engagement group where we can start testing some of this out. We're doing a review of our website at the moment, and I'm going to be really honest, I'm not a big AI person at all, but I'm trying to put my own prejudices to one side. We are trialling the use of that to enable us not only to provide information, advice and guidance at all hours of the day, because we've got the same challenge about, the office closes, what do people do in the evening, which if you're anything like me, you get home from work and that's when you start trying to find out stuff that you need. So there is, I think, a place for that and how we provide that information. But the other thing that's been really fascinating about us piloting this AI assistant is what it shows us is what people are really asking for. So not what we think we need to put on our website, what it is that people come looking for, and then we can tailor our information, advice and guidance accordingly. I think just specifically on the issue about representation of all communities and languages, in adult social care in Croydon, we are really, really blessed that our workforce actually reflects the population of Croydon, and as a result of that, we have a huge number of staff that speak all sorts of amazing languages. I love being in the office, and you're wandering around and you can hear people having conversations in Portuguese or Sudanese or wherever it might be. There are all sorts of rich languages. So, but we shouldn't rely on that. We need to constantly challenge ourselves and make sure that the information, advice and guidance we're providing is accessible to all people. And we do quite a lot of work internally to look at where we have underrepresented groups accessing services, for example, so that we can then commission specific pieces of work to reach out to those communities and really understand how we can support them better.
Wonder who's going to be answering that one. So I'll read it out. It says, what is in place to address the inequality of landing in A&E or in hospital at the weekend or bank holidays? Is that presumably because you have to wait around a lot longer at those times?
It's not that. It is the fact that services aren't available. The matron wasn't available. Doctors were overridden by staff nurses on wards for end-of-life care. Somebody was on an end-of-life plan. We were told by the A&E doctor and was made aware that the family needed to be called in, that she wouldn't be lasting, put onto a ward, and there was no communication. They wouldn't let visitors in. She died on her own because the nurse wouldn't let family members that had travelled from Ireland in to see her. And they cited the inequality of not having a good handover, because it was a bank holiday. Totally inappropriate in this day and age, totally upsetting for the family. They'd come all the way from Ireland and they were told to come back at 4 o'clock. It's wrong, and it was because a staff nurse overrode a doctor saying that she was on end-of-life care.
So firstly, I'm sorry. I can see that you're clearly involved personally to some degree. And I was going to ask the question whether this happened on a ward or in the emergency department.
On a ward.
But
I can even tell you what ward. I really don't mind. It was 103. And a complaint did go in and it has been dealt with. I can't do anything about what happened, but I can try and push so that nobody else has to go through that. And somebody dies on their own because a nurse says she can't come in.
Whether it happened on the ward or in the emergency department actually makes little difference. What you're describing is a poor experience for the patient and the family, and we have to remember we're always treating patients and their families, but probably no time more so than in an end-of-life situation. So I can only apologise. That is not something we would aspire to. I presume the complaint's being dealt with, but we are doing quite a lot of work with our palliative care teams. And we're bringing that forward. Probably the biggest step we're looking at is there are a number of patients, and this isn't for everyone, it's not always possible, it's not always preferred, but there are a number of patients who would prefer to go home, to die at home, where, it's a personal choice for the patient and family, but we're now setting that up as a service. I think what that's done is it's brought to the forefront a lot of our conversations in hospitals. I mean, if I'm honest, even in medicine as a specialty widely, it's something that's tricky to deal with. It's a bit, we don't like it because it feels a bit like failure to some, but actually we are developing that service, recognising that death is a part of life, and we need to make that as good a transition as possible. I can't defend the experience you have just described, and I wouldn't want to, but I would say we can take that to learn from, and actually that's the sort of story that we need to be sharing in our hospitals, which I shall, to make sure that when these situations arise, we go the extra mile to make sure that the end-of-life pathway is treated with just as much priority, if not more, than some of the acute illness that we deal with. Again, I'm sorry, can you
It's not that I want an apology. I just want to make sure that because it was a bank holiday, there was nobody there. And that shouldn't be that a staff nurse can override a doctor, a consultant from A&E. They shouldn't be able to override them saying, I can't say, it's not my ward, they can't go on.
That's true. And the variation of service on bank holidays and weekends remains a challenge for us. We do go down to skeleton staffing, and actually out of hours. It's funny, when you work in the emergency department, it's pretty much the same staffing levels throughout, but as you reference, it's the auxiliary services and the rest of the trust and in the community that gets less. Out of hours is the majority of the time. 8 till 5 days a week is what, 45 hours. Not a lot of time. So we do a lot of work with building, those pathways. Through weekends, it's certainly a challenge. We do look to improve it, and slowly, with increased funding and staffing models, that is improving. There are things like rapid response in the community, palliative care in the community. We are looking to address it, but I would be lying if I said we could flick a switch and change our staffing. The number of staff required to provide a 24/7 service in all aspects, it's a way off. But from my mind, what you've described in terms of palliative care, patients can die obviously any time of day, and we need to be able to provide a service that matches that. So I do hear that. Yeah.
I support people using their laptops and cell phones, and I can tell you there's a large segment of the community doesn't know how to get through these things, let alone get through AI and page to page. I've just been on it just now on the site, just telling you everything's good. And there's one thing that people do need is somebody going front to front, tell them what form to fill in. And I know I'm just discussing here this evening the carers' information budget, how complex that thing, and how many people do not claim it because one mistake on there, one budget mistake on it,
contract carers allowance, I think it's really tricky navigating some of that, isn't it? And actually when you're faced with these very complex forms, you know, if you haven't got someone there who can help you, it's nigh impossible to get through. And actually, you know, I know from my mother's perspective, she'll just look at the form and she'll just put it down again. She won't even attempt it because the thought of it is more off-putting. So that's why we do commission still specific services to help people with things like that. But it's something that we constantly need to talk to people about, understand what they're struggling with, and make sure that we've got the right responses in place. It's ongoing work to improve.
I'll be really quick. So from my perspective, yes, we do run services, but obviously in those services, languages are a problem. I mean, to have 100 in Croydon is pretty astounding, isn't it? So a couple of things that we've done to help every practice in Croydon is we've paid for Sign Live. Now I know that's not a language, but people need to be able to help engage and communicate with people who need sign language, so we've done that. In terms of when we've been trying to promote vaccination, we've actually gone to vet centres where that can be translated and trusted by people in trusted communities. One of the problems I think that we have is text messages. Now, as far as I'm aware, text messages for patients, you'll all get them, the appointments, they only go out in English, don't they? And sometimes patients are getting them on behalf of some members of their family who can't speak English, and I think that is a bigger problem, and I don't have the answer to, but with 100 languages we may not get through them all. I definitely think that's something that we can be looking into. Supporting patients how to use technology and things. It's a funny one because we hosted an event here and nobody turned up. So how do we communicate to get people to come here? So I'm going to take that away, and we need to work harder and better to get people here to help them use technology. And maybe it's the language we're not using to get them signposted here. So maybe as system partners we can do a bit more joint comms to get patients here.
So I will try to be brief, which is hard for me. No, I just really, very good. Thank you all for coming and contributing. These events, people turn up and you have, and you've got something, and it always surprises me where the questions come from and where the ideas come from. So it really makes it, it's a really good feeling that we're helping you make a difference. It's a community partnership. Just to say, really, please stay on. We have some lovely food. So we've got the place booked, at least officially another half hour, but longer. They're not ones to rush us out. So come, if you've still got your questions, you might get, if some are able to stay, please do come. It doesn't just end now. And I just want to say thank you to everyone, to our panelists. And just to say one thing, we don't know what the future is going to hold for us. It's all in its moment. For the foreseeable future, we'll stay here as Healthwatch, working for you, for Croydon residents and patients. Please keep supporting us, keep engaging us, and hopefully see you next year. Thank you very much.